now call on Dr. Hoang, and we'll find out what her title might mean.
Try to get this back to the lectern PC. One. I guess it's not an option to have the second screen. Okay, you might have to just live with one because I think the other screen, there's no option to put both screens on with video conference. Okay, well, thank you all for being here on a Tuesday morning. I have to say, I've never received so many email advertisements for my own talk. I think I got like 10 advertisements for this, which I've never gotten before, so I should be extremely, extremely flattered. Okay. So the title of this talk is Gyne with the Wind, Stories of Mystery, Intrigue, and Drama in Gynecologic Pathology Research. So for this presentation, I wanted to take the opportunity to showcase various research projects in the division and highlight some of the efforts that the students here at VGH and over at BCCRC have put in. I wanted to share some lessons that we've learned from these research projects and then provide some practical advice for the practical pathologists. I see a few in the room right now. I wanted to pose some questions for the future in gynecologic pathology research. Okay, so this presentation is divided into 3 different parts, and this is what I actually started with when I started at VGH, so we do have to talk a little bit about mesonephric carcinomas. So in order to really understand, what is it equal that? Is there a way of, oh, okay. All right, so it's just it'll just beep. In order to really understand mesonephric carcinomas, you do have to go back to a little bit of basic embryology. So in the undifferentiated embryo, there's the capacity to develop either the male reproductive tract or the female reproductive tract. And the male reproductive tract is known as the mesonephric duct, or more commonly known as the Wolffian duct. And the female reproductive tract is known as the Müllerian duct, or sometimes it's called the para-mesonephric duct. So in the developing testes, with the secretion of testosterone and Müllerian inhibiting substance, the Müllerian duct eventually regresses, and then the mesonephric duct eventually develops into the epididymis, the vas deferens, the summa vesicles, and the ejaculatory duct. Now, in females, without testosterone and without Müllerian inhibiting substance, the mesonephric duct will eventually regress, and the Müllerian duct will continue to develop, and then it fuses at its distal end, and it gives rise to what is known as the fallopian tubes, the cervix, the uterus, and the vagina. So in females, very often you can get remnants of this male reproductive tract or remnants of the mesonephric duct. And they're given a variety of names depending on where you find them. So if you find them in the broad ligament or ovary, they're called the rete ovarii or rete cis. In the uterus and the cervix, they're called mesonephric remnants. And in the vagina, they're called Gardner's duct. Okay. So in very, very exceptional circumstances, you can get malignant transformation from these mesonephric remnants. They're also given a variety of names. So in the broad ligament, they're called FATWO, or female annexed tumor of Wolffian origin. In the uterus and the cervix, they're called mesonephric carcinomas. So in essence, these are cancers that occur in females, but they're actually derived from male tissues. So life of women is hard. So mesonephric carcinomas most commonly occur in the cervix, and this is because this is where you most commonly find mesonephric remnants. But you can find tumors in the endometrium and in the ovary, and sometimes people call them mesonephric-like carcinomas. And this is actually a frequently under-recognized and misdiagnosed entity, and this is largely due to its morphologic heterogeneity, or perhaps more accurately, morphologic mimicry. And in a multi-institutional series, this is being compiled by our own Dr. Port, only 22 to 34% of cases are actually accurately picked up on a preceding biopsy. So this is a very classic pattern of a mesonephric carcinoma. It has a tubular pattern on the left-hand side and a ductal pattern on the right-hand side with sort of taller columnar type cells. So I'm glad there are a few pathologists that showed up because now you're on the hot seat. So I actually want to know your thoughts, and I'm going to show you a few slides, and I want you to tell me if you think this is a mesonephric carcinoma or not a mesonephric carcinoma. So you have a 50% chance of being correct. That's reassuring. Okay. So we're going to start here.
Cold blue, Jim Patterson Pavilion, second floor, BTHA. Code blue, Jim Patterson Pavilion, second floor, BTHA.
Okay. All right, what do you think? Mesonephric, not mesonephric? I see nods and a head shake. So this is a mesonephric carcinoma, classic tubular and ductal pattern. Yes, no, maybe so. So this is not a mesonephric carcinoma, this is a uterus, but you can still see those sort of angulated type glands. Mesonephric, not mesonephric. See a lot of mixed responses. You're giving the clinicians a lot of confidence in us right now. This is a mesonephric carcinoma or ductal pattern. Yes, no, maybe so. I see some no's, some yeses. This is a mesonephric carcinoma. This is also known as a pseudoendometrioid pattern, as you can see why. Yes. Now everyone's too scared to answer. No one is even shaking their heads now. This is an endometrioid carcinoma. Yes, some head nods. Mesonephric retiform pattern. Nobody. No, I hear no. This is a mesonephric carcinoma. This is a hobnail pattern in a mesonephric carcinoma. No, I see no. It's a mesonephric carcinoma. Papillary pattern. There's even samoma bodies to throw it off even more. A lot of whispering. It's clear cell carcinoma. It's not a mesonephric. It's an endometrioid carcinoma, chordate and hyalinized pattern. Yes, no, maybe so. This is a mesonephric carcinoma. This is a glomerular pattern. So I think the GU pathologist, Dr. Jones, would agree this looks like a glomeruli because he sees kidney all the time. He's smiling nervously. Mesonephric solid spindle pattern. Honestly, when a tumor gets solid, you're pretty much not going to be able to figure out what it is. So really the take-home point is that these mesonephric carcinomas look like a lot of other tumors. And very often we misinterpret these mesonephric carcinomas as some other more common form of gynecologic cancer. So why is this important? Well, these mesonephric carcinomas are actually fairly aggressive. And so despite the majority of these tumors presenting at low stage, about half of them will recur, and 1/3 will experience distant metastases. The lung is the most common site of distant metastasis. And in a recent study by MD Anderson, they showed that when you compare these mesonephric carcinomas to endometrioid and serous carcinomas, they actually did worse. So that's even compared to serous carcinomas. And the majority do not have microsatellite instability, they don't have POLI mutations, they don't have P53 mutations, so we can't just say that they're biologically aggressive because of P53, it's something different altogether. And the majority harbor KRAS and NRAS mutations, so they don't harbor P10 or ARID1A, or those sorts of mutations that you normally see in endometrial carcinoma. Okay, so we realized these are tumors that we frequently don't recognize, and so we started to look for a potential biomarker, and we started with GATA3 because Cleveland Clinic actually serendipitously found GATA3 as a potential biomarker. And so we looked at hundreds of our endometrial and our endocervical cases, and we compared GATA3 to some of our more traditional markers for mesonephric carcinomas. That includes ER, CT10, calretin, TTF1. And it has actually very good sensitivity, and probably more importantly, it has very good specificity. So actually, GATA3 ended up being the best marker for these mesonephric carcinomas. So that being said, there were a few different findings and some caveats to keep in mind. So GATA3 did not work when the tumor was poorly differentiated or solid, and I think that comes to no surprise to any of the pathologists in the room. GATA3 was seen in 20% of carcinosarcomas. So if you're trying to distinguish between a mesonephric and a Müllerian-type carcinosarcoma, you're not going to be able to do so with just GATA3. And this is an interesting finding. So GATA3 and TTF1 have an inverse staining pattern. So if you were thinking about a mesonephric carcinoma on a small biopsy, and you think, oh, I'm very clever because I'm going to do GATA3, it ends up being negative, you should probably do TTF1 because of that inverse staining pattern. And when you look back in the literature and you read about endometrial cancers that have TTF1 expression and then more aggressive than these endometrial carcinomas that don't have TTF1 expression, they were probably just misdiagnosed. They were probably just mesonephric carcinomas. All along, they just weren't recognized as mesonephric carcinomas. So I don't think Evan is here today, but we did try to find another biomarker for mesonephric carcinomas. And this is because I think most of the pathologists can say whenever there's a new antibody that comes out, it's very exciting and people get, thrilled about it. And then the more and more you use it, you realize the less and less specific it is. So GATA3, it stains mesonephric carcinomas, but it stains bladder cancer and breast cancer and neuroendocrine carcinomas. So it actually stains a variety of different tumors. So we ended up doing proteomics, and we tried to find biomarkers based on their differential expression, their tissue distribution based off of protein atlas, and the availability of a commercial antibody, sort of the easiest route to go down. So GST-M3 is one potential biomarker. Here it is. And you can see that the expression is mostly limited to these male-derived tissues. So this is, fairly promising. And what we ended up doing was we did GATA3 and these biomarkers on a bunch of normal male reproductive tract tissues and some female tissues. And so GATA3 actually looks like it worked pretty well, and so did GST-M3. So it seems to at least stain these male-derived tissues. And we also looked at staining across various mesonephric carcinomas, so they're organized by site on the left-hand side. And you'll see actually that GST-M3, even though it worked on these normal male reproductive tissues, it actually did not really stain these mesonephric carcinomas so well. And in comparing, and so there's three groups. There's the endometrial carcinoma, fat wall or female nipple Wolffian origin, and mesonephric carcinomas. And GATA3 seemed to work the best. It was the most specific. Each MT2 was more sensitive but less specific. And then GST-M3 didn't look like it worked at all. So what can we say? So we know that these mesonephric carcinomas are aggressive tumors. We know that they are frequently misdiagnosed. And despite all of these elaborate efforts, GATA3 still remained as the best biomarker. What we don't know is if there's a relationship between these fat woes, which are supposed to be mesonephric derived, and mesonephric carcinomas, because they don't really stain, and none of the fat woes stained with GATA3, so they seem like they're different. And there's still a lot of debate as to whether mesonephric carcinomas are really a truly distinct entity. Pathologists are skeptics. So, there's endometrioid carcinomas with yolk sac differentiation, it doesn't make them a yolk sac tumor, it just has some form of funny or divergent differentiation. So people still argue about these aspects. Okay. So we're going to move on to vulvar cancer. So when I started here, Dr. Jilts, who all of you know, he sits me down and he says, you should study vulvar cancer. And I said, no, I don't think I want to do it. But being a reasonable person, I'm going to just weigh out my options. And I think about this and I think, well, if I do this, my peers are going to give me a really hard time about this. And my co-residents, they gave me a really hard time about it. And some of my peers today still give me a hard time about it. Funding is hard because vulvar cancer
Code white, Jim Pattison Pavilion,
is not a sexy
7
disease.
alpha. Code white, Jim Pattison Pavilion, 7 alpha. Code white, Jim Pattison Pavilion,
We'll let 'em
7
go.
alpha.
And I remember meeting with the hospital foundation, and they looked at me and they said, well, you're new and shiny. What do you research? And I said, I research vulvar cancer. And they said, well, what's that? I said, well, that's the cancer of the lower female genital tract. It involves the skin surrounding the vagina. And they looked at me. I could just tell by the look on their face I was not going to be the poster child of UCHRI, and that was kind of just out the window. So funding is hard for vulvar cancer. Histology is really, really hard. And I've told this story before, but when I was a resident, I had an attending say to me, don't study vulvar cancer, don't study DVIN, because it's so hard, and if you publish on DVIN, the surgeons are going to think that we can diagnose it, but we can't do it, so just don't do it. And the derm paths, I see one in the back, they hate it. And they publish papers refuting that DVIN even exists, that it's just a form of hypertrophic lichen sclerosis, that there's no malignant potential. So it's hard. Patients hate it, understandably so. They delay coming to see the doctor about it, and then they put on all sorts of creams and home remedies, and then it makes the pathology even more difficult because it just compounds the problem. I think, I initially thought that I was doing this for the clinical need, but Blake just said that he didn't want to do it himself, and that's why he mentioned it to me. But anyways, but there really is a big clinical need because, because pathologists are so bad at picking up these preneoplastic lesions early, these patients, that sort of early window for diagnosis and treatment is just come and gone. And this causes significant morbidity for our patients. And we know this is going to be a growing problem as our population ages, and with HPV vaccination, we know that we're going to get more and more aggressive HPV-negative vulvar cancers. So I just want to emphasize the clinical need. So this is actually a patient from our own archives. This is an 83-year-old woman. She has leukoplakia, or a thick white lesion on her vulva. And this is the pathology diagnosis. So reactive atypia of the squamous epithelium and proliferation of the capillary suggestive of lichen simplex chronicus. So it continues to grow. So this leukoplakia gets worse. She has another biopsy. Pathology diagnosis, benign vulvar skin showing epidermal hyperplasia and perikeratosis, negative for intraepithelial lesion or malignancy. 2 months later, 2 different biopsies, pathology diagnosis, epidermal hyperplasia and perikeratosis with lichenoid inflammation, negative for intraepithelial neoplasia or malignancy. So this is actually very common to get a very, very wordy pathology diagnosis that almost means nothing. There is no bottom line here. And now the gynecologist is getting exceptionally frustrated, right? Because now they've done 4 different biopsies, hoping that the pathologist is going to see something. So 2, again, get a very, very long, wordy diagnosis. And 2, finally get a diagnosis of differentiated VIN. So this patient 3 months later ends up getting a resection, and it shows early invasive squamous cell carcinoma. So this is just an example of, this early window of opportunity for treatment that has just come and gone. And the reason why I think this happens is because the gynecologists or the clinicians are looking at something that looks incredibly different than what the pathologists are seeing. And so these are actually all patients from our own archives, and these are all patients who have had multiple preceding biopsies that are just given a very non-specific name, and then all of a sudden they get squamous cell carcinoma. And so, again, it's that early diagnosis and treatment window that we're just entirely missing. So I guess with things, with everything being said, it probably is worth studying vulvar cancer. Okay, so let's talk a little bit about the biology of vulvar cancer. So vulvar cancer is fairly rare. It only makes up 5% of all gynecologic malignancies. And squamous cell carcinoma is the most common at this site. It makes up 80 to 90%, and really that's going to be the focus of what we're going to talk about today. This is a good slide for anyone writing the Royal College. So there are 3 different groups for vulvar squamous cell carcinoma. There's a group of patients where their cancer is driven by HPV infection. So these tend to occur in younger patients. It's a multifocal, multicentric disease, usually associated with immunosuppression and high-risk sexual practices. And then you have a group of patients that's not driven by HPV infection. They tend to be older. The lesions are unifocal, unicentric, usually a long history of chronic vulvar irritation or inflammation. So they both can progress to squamous cell carcinoma, and the HPV pathway usually slower. The prognosis is usually a little bit better. And then in the HPV independent pathway, this usually occurs a bit more quickly. And then people speculate that there's a third pathway that's not driven by HPV, and it leads to sort of a well-differentiated, locally invasive squamous cell carcinoma that doesn't tend to go anywhere. So verrucous carcinoma is the name that it's been given historically. And if you look at some of the recent publications on the molecular underpinnings of vulvar squamous cell carcinoma, they also have 3 groups. So there's an HPV positive group, there's an HPV negative P53 mutated group, and then there's an HPV negative P53 wild type group. So I think it sort of parallels what we're seeing clinically. And not surprisingly, if you look at their overall survival and their progression-free survival, it separates into 3 different groups. So the HPV positive group tends to do the best, and then that HPV negative group, P53 mutated, tends to do the worst. So, this HPV positive group has gained quite a bit of attention. So in the most recent years, we know these patients tend to be younger, they tend to have lower FIGO stages, less likely to have positive margins and local recurrences. They're less likely to have lymph node metastases, and they're more sensitive to chemoradiation. And for the pathologists, we're not so scared about this group because we can diagnose it. We can throw in a P16, or we can do HPV in situ hybridization, and we can detect these HPV positive tumors fairly easily. So the challenge actually is this group. So this is the HPV negative but mutated or not mutated P53. And I think if you were to send everything off for sequencing for P53, we could detect all of these tumors, but as you know, that is not really practical or feasible for most of us in this public healthcare system. So I think the natural question that follows is, well, why don't we just use immunohistochemistry? Because we do it all the time. We do it all the time in the ovary and all the time in the endometrium, so why don't we just use immunohistochemistry for P53 in the vulva? And this is around the same time that Dr. McAlpine and Dr. Proctor were doing a study on vulvar cancer, and they said, can you score these P53s and P16s? And I said, sure. And I looked at these P53s and had no idea what I was doing. So sorry, Jessica, but I was really not sure looking at all these different patterns. And it was just something that I was not used to seeing as in the ovary and endometrium. So back to the drawing board. What we ended up doing is sequencing 100 squamous cell carcinomas and precursor lesions. We basically correlated the P53 staining patterns to the underlying P53 mutation status. And we were able to come up with this new pattern-based framework to assess P53. And if you are astute in using it, you can actually predict the mutation status in 95% of cases. But pathologists are not so well tuned to these patterns. So I'm going to ask the pathologists again. I feel like a lot of them are really regretting coming to this talk. But I'm going to ask the pathologists whether you think this is a mutational pattern or not a mutational pattern. The others that are not the pathologists, you can answer as well. You can throw them off. I think that's a good thing. Okay, so first slide. Nods, mutated. This is mutated. This is a missense mutation. Mutated, not mutated. I see some head shakes, not mutated. Wild type. One per mutated. Wild type, high wild type. Mutated. I see some head nods, mutated. Yes, some confident nods. This is mutated. This is a frame shift, null mutation. See some nods. See a lot of nods. Wild type. People seem to get more and more hesitant as we go along, I feel like. Mutated, not mutated. See some nods. Wild type. Mutated, not mutated. Everyone's too scared to answer now, I feel like. Wild type. See, yes, it's actually wild type. Mutated, not mutated. Yes, cytoplasmic staining pattern, this is mutated. So in addition to this framework, P53 mutation patterns in these HPV-positive tumors are really, really difficult, and pathologists are not well aware of them. And probably what's the most important finding is you always have to look for the basal layer. So the basal layer tends to have a complete absence of P53 staining. And often it's not just the basal layer, it's also some of the parabasal layers, and almost to the extent where it looks completely null. But these are all wild type staining patterns. And this makes sense, right? If you go back to HPV pathogenesis, well, HPV E6 degrades P53. So it makes sense that you're not going to see high levels of P53 in any HPV-driven neoplasm. And it makes sense that it's the basal layer that loses expression of P53 because it's the basal layer that is most oftenly the first layer that is infected by HPV, because HPV has to hijack the cellular machinery of these cells in order to proliferate itself. So, and it really is the basal layer, which is the proliferative layer. The parabasal layers are really just mature and they slough off. They're not proliferative. And if you do the HPV in situ hybridization, you'll see that the cells that don't have P53 are the ones with the highest HPV expression. So this makes sense. And we've found that even tumors that have missense P53 mutations, where you would expect it to have very, very high expression levels, also have reduced P53. So it seems like HPV is just getting rid of that P53.
Jim Patterson Pavilion North, 920 West 10th Avenue. Code red, Jim Patterson Pavilion North, 920 West 10th Avenue.
So,
red, Jim
okay,
Pavilion
building's on
North,
fire.
920 West 10th Avenue.
Okay.
Red, Jim Patterson Pavilion South,
Well,
2700
I'll just
Laurel.
say,
Code red, Jim Patterson Pavilion South, 2700 Laurel Street. Code red, Jim Patterson Pavilion South.
Maybe we really are on fire.
2700 Laurel Street.
Okay, the building's on fire. So I will say that pathologists are actually really bad at this, and I've seen a lot of consult cases. I've seen a case of an endocervical carcinoma that was called a serous carcinoma because they thought it was a null mutation. We've seen a case of a basal cell carcinoma that was, well, it was misdiagnosed as a squamous cell carcinoma, and it was only picked up because the P53 was so high, and we knew it wasn't going to be this HPV-related tumor, so it was actually a basal cell carcinoma. Okay, so a few more lessons in the vulva. So this is a resection specimen. There's DVIN in area 1, maybe DVIN in area 2, and then there's an area of lichen sclerosis in normal skin. And you'll see that there's a mutational P53 pattern in area 1, area 2, and then to our surprise, a P53 mutational pattern that goes all the way to the margin in what looks like normal skin. So when we did P53 on a bunch of resection specimens, we found that this mutational pattern went all the way to the margin in about 30% of cases. And this was associated with an increased risk of recurrence, but not statistically significant. And about, on a related note, 4% of these cases have a P53 signature. So you see this all the time, you hear about it all the time in the fallopian tube about P53 signatures. And so it does also exist in the vulva. And the other thing to note is that the morphologic spectrum of DVIN is probably a lot wider than pathologists know. So, for any of the pathologists that go and open a textbook, this is what you're going to see. You're going to see this horrible lesion with acanthosis and long ridgy ridges, and you're going to see this marked basal atypia. But in our cases, a lot of the time, DVIN was a lot more subtle than you had expected it to be. So there's atypia, but not acanthosis. There can be inflammation that obscures the atypia, or sometimes the atypia is not as pronounced as you would expect. And all of these lesions that I'm showing you had a P53 mutation, so contrary to what you would think. So a few last words for the third group, short words. So we know the third group is not HPV related, it's not P53 related. Most of the time they're PI3 kinase and HRAS mutated. And nobody really agrees on the precursor lesion. The most popular name to date is the devil. And I think it's supposed to go along with DVIN, devil. And I'll say we had a case in the department, and the pathologists love it. And these are all the comments that I heard from the residents a couple weeks ago. I hear there's a devil in the department. Have you seen the devil? Who has the devil? Why, I've never seen a devil before. So all true statements that I've heard the residents say. I love the name, pathologists love the name. I don't know if the clinicians love the name, because I don't know if they're going to tell their patients that they have the devil and now they need to be treated. Because how do you treat the devil? That's a very loaded question. Yes. This is just a case of a very recent consult case that we had 3 years ago. This was called a condyloma. So 3 years, and it grows back. And the clinician calls our dermatopathologist and says, can you review the biopsy, because it's grown back and I don't really believe that this is actually a condyloma. Can you just look at this one more time? And they send a photo, and this is what it looks like. And then the clinician says, you know what, I'm not even going to wait for the pathology diagnosis. I have already referred to GYN-onc. This is actually a case of Harry's. We're taking it out. We're not even going to wait for you. So we take it out. This is the resection specimen. Harry's not here. You can see the exophytic lesion is actually cancer. So this is an invasive squamous cell carcinoma. So again, it really goes back to us. We could have treated this 3 years ago, but here we are with invasive squamous cell carcinoma that just we let it grow for however long. But in the defense of the pathologist, this is even harder than DVIN. We have an even harder time picking this up. We don't have P53, we don't have HPV, we don't really have anything to help us. And it looks like so many other reactive lesions in the vulva. So, probably the most difficult group, but it, is probably not as aggressive as group 2. So what can we say about vulvar cancer? So we know there's 3 different groups. We do have to validate the prognostic significance of these 3 groups in a larger cohort. We have to look at this P53 framework using external cases, and both of this is already going on. We have to improve our, diagnostic accuracy, educate pathologists across the country, and this was brought up by Dr. Miller. Maybe we need to look at some new treatment approaches to vulvar cancer. Gene therapy and nanomedicines makes a lot of sense because they're topically accessible. So, okay. So I only have about 5 minutes for this last section, and I only put this in here for the learners. So when I was a fellow, I published this paper, and it described this new translocation in high-grade endometrial sarcoma. And the reason why we thought it was a high-grade endometrial sarcoma is because it looked like one. It had this sort of worm-like, tongue-like invasion, fascicular growth patterns, spindled cells, sort of myxoid. It kind of looks like a myxoid leiomar sarcoma, atypical nuclei, mitotic activity, CD10 positive, which most endometrial stromal sarcomas are CD10 positive, negative for muscle markers, so it's unlikely to be a leiomar sarcoma, and it's positive for B-core. And so these were highly aggressive tumors. They didn't respond to conventional therapy, and so we published this paper proposing that this was a form of high-grade ESS. And I was very excited about this paper, I have to say. But I didn't realize that the pathologists were not. So, I think about pathologists as being sort of very timid and maybe borderline antisocial.
Sorry, I have not add this work one thing here. Can you cut them?
Oh, sure.
Can you guys mute your mic?
Yes.
Oh, okay, thanks. One of your microphones is on. Anyhow, okay. So, so the pathologists were quite angry, which I've never really seen angry pathologists because they're really fairly muted, but they were really quite angry about this. And they said, how preposterous that you've made some new entity on some random molecular finding. Like, how ridiculous. Which was kind of hurtful, but, it's fine, it's fine. And then as time went by, people would actually send me consults, and they would say, hey, I saw this case that you described, and they had these B-core rearrangements, and more people did studies that showed that the methylation signatures and the transcriptome of YHA rearranged high-grade ESS and B-core ESS were actually very similar. And at the time, YHA was a very well-accepted form of high-grade ESS. So, if you're going to accept one, you kind of have to accept the other. And some of the critics, they actually went back into their own archives, and they actually found the same tumors, and they published on these tumors, which, made me a little bit happy, I have to say. So for the learners, don't be so easily discouraged. Maybe your ideas are bananas and bonkers. Maybe they are, and maybe they're not. So don't be too easily discouraged by other people, and just know that there's going to be a lot of new tumors that come up, and TRAC is probably the most common tumor. That's it. You made it. 20 minutes in. Oh. So I think...
Ask for questions from the telephone people.
Oh, yes. Anybody remotely have questions?
Worst advice you've ever been given, professionally speaking?
Worst advice. I think I've blacked it out in my memory, so I can't say. Probably to study vulvar cancer. I mean, that was a big one. But yeah, I don't know.
So, these are different carcinomas and their haploid relatives.
Yes.
The tumors arising from a sort of vulnerable kind of field of cells which shouldn't be where they are in a person of that
Right.
gender and age, or is there something going on sort of stimulating them, like do they locally secrete MIS or?
I don't know. I don't know if anybody knows, and it is somewhat peculiar because most cancers, especially epithelial cancers, they're connected to something. So in the colon, they're connected to and exposed to all these toxins, but these are kind of secluded. They're kind of away from any sort of lumen. So in terms of what sort of toxic stimuli they get, I don't think anyone really knows. Jessica, she's mad at me about the P53 thing.
We get that scenario walked in where people had multiple biopsies for global vaccines, had over 20
Yes.
biopsies, all of which were negative for cancer or and cancer.
Right.
You know how in psychology in the past they have a reflex statement saying if someone says they've seen something and biopsy behind, they say it doesn't replace anything and recommend more. I wonder if you need a reflex
Right.
statement.
Right.
Something like that for tree shows would be
Right.
huge.
Yeah.
Not fitting with others, but
Yeah.
it's amazing how much we get referrals after false pictures.
Yeah. Absolutely. Yeah, I think education is a big part of it. And I've said this in rounds, and it's an embarrassing thing to say, but when it comes to these lesions, I should say to the young clinicians, don't trust us, actually, when it comes to these vulvar squamous preneuroplastic lesions. We're so terrible at it, which is an embarrassing thing to say, for sure.
I think your message gets there to our general guys.
Mm-hmm.
But it's
Yeah. 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 I have three questions. Diane first.
Expand on that. I remember Greg Nelson saying that one of the most useful things is to contract these
Oh, yeah. That would be super helpful. Yeah.
I know we as clinicians are really bad about writing anything in the abstract.
Right. Or they're right about circus
If they tell you there's
tumors.
information there, that might cause
Yeah. Yeah. Helga. Yes. Mm-hmm. Mm-hmm. Yeah. Clean path. Oh, yeah. Absolutely. Mm-hmm. Mm-hmm. Yeah. Oh, yeah. For sure, for sure. Yeah, I think there's a lot of education that needs to go on, and part of it, I think, starts with pathologists humbly admitting that we are pretty bad at this, and we do need to get better at it. It starts from there, and then you need to communicate with your clinicians, share information, and that's really the only way to make things better. Dr. Ng, you're not allowed to ask questions.
We had our hotspot panel. Turn around once or twice a week, and then one talk. That was significant.
Well, I think if I was gangsta and had money to make it rain every day, it would. But are we going to really sequence all these biopsies that come in? And I don't know. It would be great. I just don't know how feasible it would be. But yes.
You could argue, but it would speed up definitive surgery.
It would.
It would have a greater impact in sequencing frank tumors.
Yeah, it would. Dr. Schaefer is contemplating about our budget and thinking about whether this is doable or not doable. Like,
what about the patients who have a past history of cancer, and we still see these series of
What if they signed that class? You not argue that those should go right to street for
You probably should.
First time we should have
Yeah.
the number of 4 and above or something like that.
Yep. Possible.
these are free passes, they go right through the panel.
Yep. Possible. Yeah. Yeah. Okay. Thank you all for